Good morning, everyone, and welcome to the Ending the HIV Epidemic, or EHE Regional Learning Collaborative Kickoff Session. My name is Elena Rosenberg-Carlson, and I'm the Ending the HIV Epidemic Coordinator here at the Center for HIV Identification, Prevention, and Treatment Services, or CHIPS, at UCLA. We're going to start off with a few polling questions to learn a little bit more about all of you. So you should see 3 polling questions popped up on your screen, and you can scroll down if you can't see all of them at once. The first is, where do you work? What best describes your primary affiliation? And what kind of Zoomer are you? Take just a few more seconds. All right. So where do you work? Great, so we have some folks from each of the 8 EHE Phase 1 jurisdictions in California, with a great group of folks, particularly joining from LA County. And then we even have a few folks from other California counties and joining from outside of California. So welcome to all of you. Looking at your primary affiliation, it seems like we have a good group of folks from public health departments and academic institutions, as well as community health clinics, particularly. So a great range of folks from different affiliations. And then we have a lot of different types of Zoomers, but it seems like having your camera off is very popular with this group. And it's not quite as common to be wearing business casual in a well-lit room with no distractions. Next slide. So as some of you may know, CHIPS received a 1-year supplement award from the National Institute of Mental Health in September 2019 to engage a regional effort for coordinated EHE response in California. And to do this by bringing together stakeholders from the 8 California EHE Phase 1 counties, which occurred at an all-day meeting in January, as well as a virtual follow-up meeting in April. And working with all of these stakeholders to assess key needs, collaborative opportunities, and existing resources for a coordinated EHE response. The findings and recommendations from this project were compiled into a report to help facilitate a regional EHE response. Next slide. So the EHE Regional Learning Collaborative, launching today, was created in response to stakeholder recommendations from the Supplement Project to create a learning collaborative infrastructure for the EHE regional response. The goals of the Learning Collaborative are to facilitate knowledge sharing and spark collaborative opportunities across California's EHE Phase 1 counties, and to ultimately build readiness for coordinated action on the identified EHE regional response priorities, which you can see on the slide below. Next slide. For today's kickoff session, which is building our coalition to end the HIV epidemic in California, we have an opportunity for all staff involved in HIV services across California's EHE Phase 1 counties to come together to learn about the EHE initiative, current and future EHE efforts in California, and ways to engage. This session aims to help address the EHE education workforce development priority identified by regional stakeholders. And it's also a great opportunity for those already familiar with EHE to find out more about EHE activities happening now and happening soon across the region. We have a great group of presenters who will take us through an introduction to EHE and the critical role we all play in the initiative. EHE efforts in California, and a county health department panel on EHE activities happening in each of the phase 1 jurisdictions. I just have a couple of quick housekeeping items before we get into our first presentation. One is to please feel free to submit questions at any time during the session by selecting the Q&A button on your Zoom control panel. The last portion of today's session will be dedicated to answering your questions. We are recording the session and we'll be posting the recording on the CHIPS website within the next week or so on a new webpage dedicated to the EHE regional response. After the webinar, I will send out links to the session evaluation form and the new webpage. Please complete the evaluation. We really want to hear your perspectives on today's session and any suggestions you have for future sessions. We also invite you to check out the new webpage and let us know of any additional resources or information that you'd suggest we add to support the EHE regional response. We'll be updating the page regularly with new resources and opportunities to engage. Next slide. And now I'll turn it over to our first presenter, Commander Michelle Sandoval-Rosario, who is the Region 9 Prevention Through Active Community Engagement, or PACE, Director with the Office of the Assistant Secretary for Health. Welcome, Commander Sandoval-Rosario.
Great, thanks so much. It's an honor to be here, and I'm excited to hear from all of you and our panelists. And I'm sure many of you have already seen the slides I'm going to present, but I'm hoping that some of you, this is new information, so I'm looking forward to our discussion. Next slide, please. So of the 1.2 million individuals living with HIV in the United States, we know that about 56% of them are virally suppressed. And we know that those who are virally suppressed are linked to care successfully and can successfully take medications. But we also know that we still have over 36,000 new HIV transmissions in the US, and we have really plateaued that number for many years and have not been able to move the needle. So as we continue to do what we are doing today, we have to really think outside the box, or else we're going to continue having over 400,000 new transmissions in the next 10 years. Next slide, please. I love this slide because it really shows us that today we have the data, we have the ability to use the data in many different ways where we can identify communities and areas with the largest burden of HIV. We also know that antiretroviral therapy, when accessible and used correctly, is really successful in not only keeping people alive, but also prevents the transmission of HIV to others. Also, we know we have the biomedical prevention tools such as PrEP, but the reality is that many communities still don't have access to PrEP, and many of them do not know about it. And we all know that this is not uncommon. We've also been doing this for over 25 years, and all of you there are experts and have been fighting the epidemic for decades. Between our colleagues at HRSA, CDC, NIH, with their work with the CFARs, we have the proven models in both care and prevention that we can apply and we can modify to the communities that we serve. Next slide. So ending the HIV epidemic is a national initiative about using all these tools in our toolbox to be able to reduce new HIV infections in the next 5 years by 75% and at least by 90% in the next 10 years. So really, what does that mean? That means that within 10 years, we want 3,000 or less HIV transmissions in the US. It's a focused effort geographically on 48 counties, and that includes DC and San Juan, Puerto Rico, which we know account for more than 50% of all new transmissions in the US. And we also have a focus on 7 rural states where we also know we have a large burden of HIV. I also want to point out that this is an HHS-wide plan, and it really focuses on the agencies you see listed here on the screen. They play a key role, and they have a key role in moving the initiative forward and have received direct funding from Congress that is coordinated from the office I sit in, the Office of the Assistant Secretary for Health, to be able to implement and support EHE initiatives across all jurisdictions. Next slide, please. So in addition to the overall goals I mentioned, the initiative sits on what we call the 4 pillars or the 4 elements. The first is diagnose all people with HIV as early as possible. And this is really an opportunity for us to think about where testing is not only available in those traditional public health settings, but also where we can make HIV testing available in non-traditional settings. So how can we make HIV testing more available in emergency rooms, jails, through churches and community fairs? So that's really is the key, to be able to be innovative. Diagnose is the first pillar. Then we have treat. So those people living with HIV, linking them to care within 30 days. And what we know today is that the earlier and sooner we can get someone into treatment, the better their health outcomes. The next one, preventing new HIV transmissions by using our entire prevention toolbox. So I really want to focus on that. So we're not only talking about condoms, but we're also talking about PrEP, PEP, behavioral change, and also syringe services programs, which we know the science has shown can really make a huge impact in curbing the epidemic. And then responding, being able to use our surveillance data to be able to identify clusters in HIV and within geographical areas, so we can bring our prevention toolbox as well as our care and treatment to those who are positive, so they are linked to treatment as soon as possible, and also our prevention services, so those who are at risk can benefit. So these are really the 4 key strategies that we'll be hearing from our panelists on how they're implementing in their jurisdictions. Next slide, please. EHE is an administration priority, even in light of COVID-19. And we really have seen some tremendous changes through our healthcare system in just these last 6 months, in the way that we approach providing not only HIV care, but HIV prevention services. We want to maintain a balanced approach to be able to move the EHE forward, even given this COVID-19 pandemic, because we know it's going to be here for a while. So we want to still continue to move this forward. And I always like to point this out, that we're talking about people's lives. We're talking about at least 36,000 new transmissions if we don't do something differently, even during these difficult times. This means that we need to continue to expand not only HIV testing safely, but we also have to think about how we shift from telehealth and telemedicine models to provide care and treatment, and how do we provide prevention services during this time and doing it safely. Next slide. So I want to talk a little bit about the first pillar, because it really is what's going to move us forward. We know that 8 in 10 of new HIV transmissions come from people who are not in HIV care. And this really shows us the importance of scaling up HIV testing and diagnosis. Many of those who test positive and don't know they had it, we know put others at risk. And we also know that many studies have shown that someone who knows their HIV status tend to change their behavior and are also more protective around those around them and also their sexual partners. So we definitely need to look at different ways to be able to scale up HIV testing during these times. Next slide, please. We also know that HIV treatment prevents new transmission, and this is really a key message that healthcare providers need to be able to deliver to individuals about the importance of care and treatment, and that treatment is now safe, it's easy, and it's more tolerant than it was before. And this whole message on U equals U is both an empowering message, and it helps individuals take control of their health, and it helps eliminate some of the stigma that people living with HIV face. Because one of their greatest fears is that they will transmit it to someone else. So being able to talk to them about the importance of treatment and adherence. So we really hope that our healthcare workforce continues to deliver and multiply this message. Next slide, please. HIV testing is our gateway to either prevention or treatment. It really is an important component and very important, which is why it's the first pillar of ending the HIV epidemic. So again, looking at ways we can expand HIV is key to these efforts. So within our communities, how can we make HIV testing more accessible and available to individuals? And another thing to think about is that a lot of studies have shown that sometimes even STI clinics, individuals who show up with gonorrhea, chlamydia, syphilis, might not be offered an HIV test. And this has been shown to be very prevalent among the African American Black community. when they are not offered an HIV test, and then within a year, they are having positive HIV test results. So we have to really think about not only how do we expand HIV testing, but also how do we capitalize on some of these missed opportunities when it comes to HIV testing. So as we think about syndemics, there are opportunities that we are missing, especially in communities where these infection rates are highest and where communities are disproportionately impacted. How can we capitalize on some of the missed opportunities to be able to address some of these syndemics? So COVID testing, STIs, and HIV. Next slide, please. So one of the many prevention tools that we have for those who are at risk of HIV and are negative include PrEP. One of those things we have done at HHS is to start a national PrEP program known as Ready, Set, PrEP. And PrEP, as we all know, is a medication that when taken effectively, we know can reduce the risk of those getting HIV. And the medication is simple and easy to take. And we have two medications, Truvada and Descovy. Descovy is currently not recommended for cisgender women, but Truvada is. Both of these medications are available and can reduce the risk of getting HIV for those who are at risk and HIV negative. And the exciting thing about the Ready, Set, PrEP program is that it's for those who are uninsured and qualify, and the medication is available at no cost. So those who are eligible for Ready, Set, PrEP have to have a negative HIV test, a valid prescription, and have no health insurance. And they can pick up their prescription at more than 26,000 pharmacies throughout popular chains in the US, including Puerto Rico, DC, and the Virgin Islands. And at HHS, we have worked really hard with community pharmacists across the US to continue to expand that network to make it more accessible. And I also do know that the state of California has a very robust PrEP assistant program. So we are working closely with the Office of AIDS to see how do we integrate both of them to be able to make PrEP more accessible for communities. Next slide, please. So these are our core indicators for ending the HIV epidemic. Diagnose people with HIV is the first indicator, followed by knowledge of HIV status, linkage to HIV medical care within 30 days, viral suppression, PrEP coverage, and our ability to respond, which unfortunately we don't have an indicator, but we know is very important. These are our key indicators that line with those 4 pillars that I discussed in previous slides. Next slide, please. We're very excited of the release of the dashboard known as EHE. This is an opportunity for jurisdictions to really see where they are. The dashboard allows us to visualize EHD data, and I really hope that it's a way that we can be transparent to not only our stakeholders at all levels, but also the public to know where in our efforts we are with the HIV epidemic. It has baseline, targets, and progress for all of the 6 indicators, and we're continuing to add to it. Just a few up, we're going to be adding all states, even those that are not part of the first phase. You'll see data, but you won't see target for them. In the next 2 weeks, either next Friday or the following, we're going to add Q1 and Q2 preliminary 2020 diagnosed data. And then we'll also be adding Q1 linkage to care for 2020. And I do want to note that the preliminary quarter data that's added in the dashboard is cumulative, meaning that you will not be able to see each quarter individually, but it's added. And I'm most excited that we're going to be adding an interactive functionality where you'll be able to download some of the graphs, some of the data. And we're also looking to include 6 specific social determinants of health of indicators, because as we all know, if we're going to address the epidemic, we need to address housing, transportation, poverty. So we'll be able to see how that looks across not only states, but jurisdictions. So more to come on that, but we're very excited. Next slide. So for the first time in the US, we have put together indicators of where we need to be to get to 3,000 or less HIV cases by the next 10 years. So again, this is just a visual for you all to see what those indicators are, and including leading measures and overall goal. Next slide. So I just wanted to put some snapshots of a couple of county data. I have here San Bernardino. You can see I have incidents, the number of new HIV in a given year, and you can see that we have baseline, quarter, so that's going to be updated, and then where we want to be in the next 5 and 10 years. Knowledge of status, estimated percent of people with HIV who have received an HIV diagnosis. Next slide. And then I've included some data for Sacramento, looking at diagnosis, and then looking at linkage to HIV medical care. So again, it's really nice to be able to see where we are and where we need to go and where we need to do more work. Next slide. And then I added some data for Orange County, viral suppression. You know, viral suppression is an area that all of our counties across the US are struggling. You know, how do we not only get people into care, but make sure they stay into care? We also have PrEP coverage. I know many of our partners have struggled in identifying how do we measure PrEP coverage. So it's not a perfect estimate, but this gives us an idea of where we need to go and how to go there. Next slide. So finally, you know, what can you all do to support EHE? Number one, know your status. Everyone should be getting tested. Encourage and support testing across different sectors and communities, including academia, churches, business associations. Also thinking about, are there opportunities to combine COVID testing with HIV and STIs, and how can we do that in this virtual world? And then how do we encourage and influence individuals within our own sectors, in our own circle, to get into care and get virally suppressed? Next slide. This is the most important slide to me. If you could take one thing, I really want us to think about EHE as a whole of society initiative. This is where we need to really be reaching out with non-traditional sectors who have not been part of the HIV conversation, because the reality is, if we really want to move the needle and get to our goal in the next 10 years, we need to be talking to partners and community at risk that public health traditionally has not done a good job at. So I really challenge you to think about, how do we work closely with the business community? How do we work closely with the faith-based community, with our private sectors? And that's really going to be a game changer for us. Next slide. Finally, my last slide, just to put in a plug here, the PACE program is collaborating with HRSA and CDC and our partners from San Diego to put together a town hall looking at EHE and how it impacts the Latinx, the Latino and Hispanic community. And I'm excited that this is going to be an all Spanish town hall. So I'm hoping that you can disseminate the flyer to your communities, to partners that serve the Latinx community, so we can really hear from them how we can better serve the monolingual community. Next slide. And other than that, that is all for me. I hope I stayed on my time, and I'm looking forward to questions and discussions. Thank you.
Thank you so much, Commander Sandoval Rosario. That was a great overview of the Ending the HIV Epidemic initiative. Next up, we have Kevin Sitter, who is the Ending the Epidemics Program Manager at the California Department of Public Health Office of AIDS. Hi, Kevin.
Good morning. Thank you, everyone. And I'm very impressed about how many people are on the webinar. I like the dedication towards ending the epidemic. Thank you. This slide has a little meaning to it for me. This is a tricolor Ending the Epidemics title. The red represents HIV, the yellow represents hepatitis C, and the greenish around the corners is STD. We need to start integrating and get a marriage of HIV back with the STDs and hepatitis. So in 2016 was the first time HRSA and CDC got together and said, hey, let's make an integrated plan, and requested each state or jurisdiction to create an integrated HIV surveillance, prevention, and care plan. For the state of California, we defined 4 goals at that point: reducing new infections, increasing access to care and improving the health outcomes for people living with HIV, reducing HIV-related disparities. Sorry, I forgot to turn on my timer. I don't want to go over for you guys. So, So increasing access, then reducing HIV-related disparities. Actually, instead of reducing, we wanted to eliminate the disparities. And we need to achieve a more coordinated statewide response to the HIV epidemic. As Michelle's last slide showed you, this coordinated statewide response is going to take the whole community, all sectors, everyone working together. Let's go the other direction. So in California, our viral suppression rate currently is 64.2. But I think it's important to look at viral suppression relative to, first of all, linking the newly diagnosed. 79% of people in 2018 were linked within 30 days to HIV care. The result was within 6 months, 64% were virally suppressed. 89% were linked to care within 6 months, and the result was at the end of 12 months, 70% were virally suppressed. You'll note that the increase in viral suppression wasn't as significant between 6 months and 12 months as it was between 1 month and 6 months. It is key to get people linked to care quickly. It's shown that people who are linked to care within 30 days are likely to stay in care longer and ongoing compared to people who delay their linkage to care. Secondly, let's look at all Californians diagnosed with HIV. All Californians diagnosed with HIV, we've got a rate of about 55%. That includes the people that were not diagnosed yet. So those people living with HIV, unaware of their status, and people diagnosed. If you look at people who had one visit or more in the last 12 months, we see that the diagnosis is 90%. And so viral suppression is achievable with medications and is simple to reach with medications and visits. If you don't have care in the last 12 months, notice it goes down to that 64%. And so it's critical to link people in care and keep people in care to achieve that viral suppression rate that is so important. So PrEP is the other element. Viral suppression and PrEP are the two key activities that will get us to our goal of less new infections. And so we have our work from AIDSview showing us where we're at in 2018 was 27,200, 300 people. This is where our indicator shows we should be going. So at this rate, we will not achieve our goal of 60,000 people on PrEP by 2025. So to increase the efforts of PrEP, we've got the PrEP Assistance Program, the program that's available to anyone in California, any resident in California, regardless of serostatus, regardless of immigration status. And the PrEP Assistance Program goes up to 500% of poverty, which is about $60,000 a year income for an individual person. So a liberal PrEP assistance program. It also pays for the clinical visits. It pays for any screenings for STDs, HCV, and it'll pay for the treatment of STDs as well. We've contracted with a telehealth provider so that people who are not close to a PrEP provider can still access PrEP through the telehealth program. We've got a new team in the ADAP section. The PrEP money comes from rebate and from legislative dollars. And so it sits in the ADAP program, although it doesn't use any of the Ryan White ADAP dollars. But the PrEP team up there is going to now concentrate on both marketing, enrolling people, and monitoring to see where there are gaps and where we need to strengthen our outreach to individuals. All enrollment workers are now being duly trained to be ADAP workers and PrEP enrollment workers. This is going to significantly increase the amount of access to PrEP. And lastly, we fund PrEP navigation programs to be able to initiate PrEP navigation programs that are intended to be sustainable after the funding is removed. These efforts should move us from the trajectory that we're at to where we need to be in the next 5 years. the increasing access to healthcare and improving health outcomes, we can see that we've got a Nike Swift for our continuum. And that is that there are more people that have achieved viral suppression that are retained in care. However, this retained in care definition is a HRSA definition of 2 visits per year. If we were to look at 1 visit per year, this would be increasing and would see the viral suppression rate would increase as well. So we've got the people who are infected, we've got the people who are diagnosed, and so we see the gap in who needs to still be identified and provided services and supported. We see that our linkage to care needs to be increased as well, and then our retention and care. Each of these are events that we can work on through everything from outreach through medical case management. It's about inquiring at the food banks whether people are in care. When was their last appointment? When is their next appointment? Those 2 questions can be critical in identifying people in care or not in care. When was your last visit? When is your next visit? So the data to care is one option that we're using to identify people. We understand that the data to care lists include a lot of people that are in care, but it's not documented or they've moved. We understand there's a lot of people in data to care who have moved out of the state. There are people who have died. And so keeping surveillance data up to date is an important part and will become more efficient as we can dedicate more time to surveillance. COVID is taking its toll on basic surveillance, but it's also taken a toll on something called LISA. LISA will be an integrated software program that will pull data from ADAP, from EHARS, from ARES, from LEO, and put it all together so that the primary information is now accessible to people who have access to it. Access can come in at different levels, but it will allow partner services to coordinate so that there's not a different person going out to speak to the dual diagnosed syphilis individual. Someone saying, hey, you've got syphilis. Someone else saying, hey, you've got HIV. Let's integrate it and say, hey, let's talk about your sexual health and what we need to bring you to a better healthy condition. Our outreach and screening of all Ryan White clients is the point that I made already. Last medical visit, next medical visit. And we need to increase our collaboration between our non-Ryan White providers and patient navigators. We have a lot of talented CBOs that know their people and that are out on the doing the boots on the ground. And we've got some physician systems that don't leave their office. Let's bring in the people that have the talent of reaching out to people and serve the non-Ryan White clinics so that we broaden not only our Ryan White successes, but our success in providers that are non-Ryan White affiliated. This is a dashboard that was spoken about in the last by Michelle, and it shows our baseline, and it shows the statewide incidence, knowledge, diagnoses with some preliminary. We'll know that this preliminary will refine. We expect this to be higher for 2019 in the end, but that's part of what, when the quarters come out, we need to be cautious about the final results. Often take a couple of years before everything settles and we know what's what. So this is the California Consortium, our 6 counties that you're about to hear from that are doing ending the epidemic work in cooperation with California. Los Angeles and San Francisco are independently reported. The amount of people covered in California who are living with HIV through our 6 counties is 33.8%. When we add Los Angeles and San Francisco, our current phase 1 ending the epidemic efforts will reach 81.2% of all people living with HIV in California. So the funding coming in for 2020-10, for 07-8, for 91 will really help most people in California and will impact the epidemic significantly in the next 5 years, so that in the following 5 years, there is very little left to be able to achieve the final goal 10 years from now. In addition to the federal plan, the Office of AIDS is creating an Ending the Epidemics strategic plan. This will update from the integrated plan, and it's time to address the syndemic of HIV, STDs, and HCV. So the strategic plan will encompass everyone. Sorry, got to drive this phone. I'm almost done. We have a common set of communities impacted by most HIVs, STDs, and HCV. And there's also similar behavioral acquisition, disparities, and social determinants of health. So it's time to bring them all together and address them comprehensively and inclusively. Comprehensive screening is the imperative element. It all started when the HIV epidemic, or AIDS epidemic at the time, had to treat HIV distinctly due to the discrimination, fear, and social consequences. We've achieved better parity, we've achieved less stigma, less discrimination. We have protections for people living with HIV now, so that if we only test for HIV or STDs or HCV, great opportunities have been missed. The lab platforms available now allow for testing for all three infections simply. And so it's time to leverage the additional funding, screening that can be brought when we talk about a syndemic approach and addressing all three at once. So this is where HIV will be going in the Office of AIDS towards a merge with STDs and HCV. COVID has taken a toll, so this has been slowed down, but it is our vision and where we'll be leading in the next year to 2 years. So that's my presentation. We're going to have questions later. I hope you've been putting them in the Q&A, and I'm going to pass it back over to Elena. Thank you.
Perfect. Thank you so much, Kevin. Now we're going to move into our County Health Department panel, and we'll begin with Steve Gibson, who's the Director of the Office of HIV Prevention for Alameda County. Hi, Steve.
Hi, good morning. How are you?
Great, thanks for joining. Thanks
everyone for joining us today. Very happy to have you here. I'm here to tell you about a little bit what's going on with our HIV prevention activities in Alameda County specifically. So in Alameda County, our priority populations that we're looking to focus on with this set of funding is looking at African American and Black and Latino MSM, young MSM of color, specifically looking at men 30 years and younger, transgender people, which includes both transmasculine and transfeminine people, and PrEP eligible women. And by PrEP eligible women, we're talking about women who have HIV positive partners, women with multiple sex partners, women who use drugs, women who are homeless, as well as women who engage in sex work. Next slide, please. So for those of you who don't know how Alameda County is structured, we do not have a municipal STD clinic. So Alameda County does not provide direct services. We will issue an RFP for services under this activity. And those services are going to include, that we're going to be issuing for RFPs, include HIV testing, including routine opt-out testing in healthcare settings, as well as testing outside of clinical settings. And this is a shift due to COVID that we're taking on right now. We realize now that our focus testing sites have closed down and are not going to be opening in the foreseeable future, as well as an opportunity to engage people in HIV testing who wouldn't have sought out a test elsewhere. We're also going to focus on telehealth for this as an aspect of that as well, to make sure that we can get people who are not willing or able to go into a clinical setting. Other services that we're going to include for under the RFP are looking at same-day PrEP for Alameda County priority populations, as well as PrEP for gay men and MSM diagnosed with STD. This is specifically going to be following up on the CDC's recently issued NOFO for community-based organizations. In their NOFO, they're looking for a referral for PrEP. In Alameda, we really want to look at linkage and initiation of PrEP as a priority outcome that we're looking to fund and support. Things that the county will be taking on as an activity are expanding to data to care and data to PrEP. And specifically, our STD unit is chronically underfunded and has had to limit its focus on women who are diagnosed with syphilis. So we, with these funds, will be looking at MSM who are diagnosed with STD and looking to initiate PrEP with them and be able to follow up with them and offer PrEP more robustly, as well as expanding data to care. Right now, Alameda County only has one public health investigator who's working on HIV partner services, and she has currently been activated for COVID for 4 days of the week and focusing on HIV care 1 day a week. So we'll be hiring a new public health investigator who will focus on partner services, specifically linking people who are newly diagnosed to HIV care. Next slide, please. This is just a broad overview of some of the activities that we've been engaging on, both from the Office of HIV Care as well as the Office of HIV Prevention for ending the epidemic activities. Not going to go into detail here because there's a lot in front of you. We did have to shift quite a bit with COVID. A lot of our activities that we're planning on doing were going to be in person. So with the support from the state, as well as Facenta Consulting, we've been shifted, and top bar, looking at the far right, some of the activities that prevention is engaging in is looking at online surveys for trans and cisgender MSM of color, as well as interviews with our leaders in the African American and Black community in Alameda County. I will say there's something up here that's just popped up that's not on this timeline, is that my office is going to be holding a meeting at the end of October to look at PrEP guidelines, specifically looking at PrEP guidelines based in New York State, and how COVID has affected our ability to engage people around PrEP. Next slide, please. Thank you.
Thank you so much, Steve. Now we'll move on to Matilda Gonzalez Flores, who is the Program Manager for HIV Planning and Coordination with Orange County.
Hi, good morning, everyone. So thank you for the opportunity to provide some insight into some of the ending the HIV epidemic work that's happening in Orange County. And really, I'd like to use this opportunity to provide insight into the work, but also use it as a call to action for folks to get involved and to really help inform both the planning and the implementation of the ending the HIV epidemic activities. On the slide, you're going to see that I have the contact information for a couple of key staff, including myself, as well as our grant manager and ending the HIV epidemic staff specialist. So again, as this is a call to action, please feel free to follow up after to get in touch and learn how you can get involved. Next slide, please. Okay, so here we have our priority populations listed. And again, these priority populations were identified based on the available data. And we were looking to see what communities were most affected by HIV and disproportionately affected by HIV, as well as looking to engage those voices that haven't been traditionally at the table to inform both the development of our ending the HIV epidemic plan and implementation of activities. So you hear in terms of priority populations is Black, African American, and Latinx MSM, people who inject drugs, youth, transgender individuals, as well as PrEP eligible individuals and people living with HIV who are not virally suppressed. Next slide, please. In terms of planned activities, what you see listed here is a broad overview. And again, these activities align with the 4 pillars of the EHE initiative. And it's important to note that these activities really are meant to support and enhance the work that's going on in Orange County. Again, to support the efforts that are ongoing and not replace. And lastly, the activities were developed in collaboration and with input from the community and certainly our EHE steering committee. So a quick run through here, we're looking into piloting a home test kit program, as well as taking the services to where the need in the community is through a mobile testing care and referral services program. We're also building on some of our previous successes in implementing health summits for gay men and transgender populations. Again, this was something we did in previous year, and we got tremendous feedback to be able to replicate and continue to bring these type of activities to the community. Then we also have some formative research activities, including health education videos and some focus groups to help inform some of our other activities listed here. We have trauma-informed prevention and care services for African American and transgender populations. And this is really looking to hone in on building the workforce capacity here in Orange County, and also ensuring that the services are truly meeting the needs of the community. We have a patient incentive program, and then also bringing some additional services, for example, community-based case management services out into the community, because we know that outside of the Ryan White system, the outcomes can certainly can use some support in terms of this area. Next slide, please. And what you see listed here is, again, our planned and as well as some of our implemented community engagement activities. And again, this is, again, where I'm gonna emphasize the call to action of any of you are interested in getting involved, again, to inform the development of our Ending the HIV Epidemic plan, or to support in the implementation. Please look us up. We're on ochealthinfo.com. Look up HIV planning and coordination. And again, we wanna ensure that these activities are really reflective and meet the needs of the community. So your voice matters, and we hope that you also get involved. Again, we have some things and some activities in the works. We also had to sort of retool our approach because of COVID, but we're gonna keep plugging along again to ensure that the critical voices are being heard and captured. Thank you.
Thank you so much, Matilda. Next, we have Leah Morgan, who is the HIV STD branch chief for Riverside County. Welcome, Leah.
Hi, welcome to everyone, and thank you for coordinating this wonderful effort where we'll be able to share our plans and then discuss with our colleagues information and things that are going on with them in their counties as well. So we don't all have to reinvent the wheel. We can learn from each other and actually reduce the HIV epidemic in America. Next slide, please. So one of the things that we did in Riverside County was really look at what was happening currently. So in prior years, we would see a large number of cases in the eastern portion of the county. And we started to see within the last few years that the epidemic was actually shifting. The demographic had actually changed. And so now we're seeing a lot of young MSM of color. Actually, 42% of our cases also were younger, under the age of 30. And so again, I mentioned that they were now more in the western part of the county and in the southern part of the county. So that means like Riverside City, Paris, Temecula, and those areas. And then because the demographics had changed, the areas we have to focus on changed as well. The methods that we were able to use in the eastern part of the county have to be tailored for our current population. So our plan is to bring those, as you see on the slide, that are voices but are not at the table, but are disproportionately affected. One of the things we can't miss, or we have to ask ourselves, is why aren't they at the table? So we have to look at some of the underlying causes and reasons that people would not be included. And so in looking at that, looking at different structural racism, different things that people encounter when they go to a provider's office, we have to address those as well, including providing a means for self-advocacy, and then also preparing providers that when they receive clients, that interaction between the two can be positive. And then also looking at new partners. We realize as a health department, we cannot reach everyone that needs to be touched with this epidemic. So actually bringing in partners that may have different skill sets that we have. I think it was Michelle mentioned earlier that we're looking at businesses. So businesses have a whole different way of interacting with their public. So they are good at marketing. They are good at different things that we aren't good at as public health officials. So, and then also being able to speak the language. I think in this area, we're good at speaking public health, but now we need to be able to translate that into the language that people are speaking so that they get the message that we're trying to relate and are actually able to benefit from some of the resources that we have for them. So our plan of priority populations are Black, African American MSM, Latinx MSM, and residents of the Midwest and southern parts of the county, and then those that are under 30. Next slide, please. And so, as I mentioned earlier, our plan includes a process to work with providers to actually incentivize their work around PrEP. So we noticed that when we're looking at the data, and Michelle and Kevin mentioned the dashboard, we're doing pretty good with cases, the case rate, as well as viral suppression, but we noticed a huge gap in those that were eligible for PrEP versus those that were on PrEP. And so one of the things that we're going to do is become a PrEP AP site so that we are able to actually go ahead and help enroll people onto PrEP. The other thing we're doing is we're going to be working with the health plans to make sure at a broader level, the providers are receiving information about sexual health. We just want sexual health to be normalized in that provider visit. So if they're going to, not necessarily about a sexual health problem, but just being able to talk to their provider if they went in for a cold, or if they went in because their knee was hurting. Just being able to have that interaction with the provider that's positive around sexual health will increase testing and then PrEP and prevention. So then also a testing initiative for young MSM of color. We really need to make sure that people are aware of their status. And so looking at our data, it looks like there's about 1,000 people per year that are unaware of their status. And so for us, that will include different testing, not just at the health department, but also out in the community where people are. And then the rapid starter pack and retention program. So making sure that we have boots on the ground that are able to work with individuals that get onto PrEP and make sure that they stay on PrEP as long as they need to. In our Riverside County, we actually do have a specific HIV clinic where we're able to see HIV positive patients. So one of the things that we're doing is increasing the number of people that can come for STDs as well. So we don't have a specific standalone STD clinic. The clinic is more focused on HIV. However, since we have providers, we're able to cross those different areas and be able to offer more services with the providers that we do have. And then network investigation and intervention. So that will include partner services activities in a broader sense. So about a year ago, one of our staff members went to a conference, and they were talking about how they were doing partner services. And one of the things that they did was they had investigation parties where people that were in a certain network were able to come and get tested. They incentivized them, and then they followed up on them. So those that were positive ended up getting treated, and those that were negative were either given PrEP care or education, enrolled in PrEP or given education, other prevention. And so those are the things that we're looking at as well. Next slide. And so key in our plan, we wanted to make sure that as we were initiating a plan, we got community input. So we had a number of community forums, as well as I have to mention the Inland Empire HIV Planning Council have been really, really instrumental in helping get the word out and helping provide us input. So we can't thank them enough for that. And then also in 2020, all of us went more electronic with COVID. And so we're just doing different things around that and having webinars and focus groups with folks online. And then the other thing in moving forward is we still want to have continued community input. So this is a 5-year plan. And so all along the process, there'll be surveys, see how we're doing. We'll have the dashboard just to make sure that the work that we're doing, those things that are successful, we continue with that. Those things that need to be tweaked, we're able to do that as well. So anyone that is interested in joining us, my contact information was on the first slide. You can also go to rivcoph.org and Oh, there it is. Thank you. And then the other thing is that we do have a medical school in Riverside County. And so one of the things we'll be doing is leveraging that relationship to make sure that providers that are in school now being trained are aware of the HIV epidemic, the STD epidemic, Hep C epidemic, and that way we can work together to reduce all of those disparities. Thank you.
Thank you so much, Leah. Next, we have Shell Gossett, who is the AIDS Director and Senior Health Program Coordinator representing Sacramento County today.
Good morning, everybody. Thank you for joining us today. Next slide, please. So for the Sacramento County portion of the PS 2020-10 Ending the Epidemic project, our priority populations are listed here on this slide. We have youth 29 years and under, including transitional age youth, Black, African American, and Latinx MFM, people who are unhoused, and PrEP eligible individuals. These priority populations were determined within our stakeholder groups that we had, and in 2019, and that's just how they were determined. So next slide, please. So we are planning a startup Wellness Without Walls W3 clinic with this project. The W3 mobile unit will take sexual health care out of the clinic. It will offer HIV testing, linkage to care, and PrEP initiation and navigation with a focus on unhoused communities, persons up to 29 years of age, and transitional age youth, and including people who inject drugs. The clinic will embed HIV-related and sexual health services with a menu of broader support services needed in our priority populations, including mental health and substance use counseling. The mobile unit will reduce physical, social, and psychological access barriers to access HIV and STI services in Sacramento County. The Mobile Wellness Without Walls clinic will be a part of a coordinated and comprehensive sexual health services, including HIV treatment and care, funded by our HRSA Ryan White Ending the Epidemic funding, the HIV STD surveillance and disease intervention services, and our testing and prevention services, including new funding, a new program funded by SAMHSA's Ending the Epidemic, providing HIV prevention and education to at-risk youth, including homeless and other vulnerable youth populations. Here in Sacramento, we have a sexual health clinic that provides STI services, and we're hoping that the mobile clinic will work in conjunction with that, with our youth-friendly clinic, and we're just hoping to, reach the priority populations that we've mentioned. So the next slide, please. We've engaged our Ending the Epidemic community forums. Due to COVID, some of our activities have been limited, as mentioned, by other counties. We have sent out an online survey to several hundred participants. Our online surveys will continue to be ongoing. We will have key informant interviews with people who inject drugs, and we will continue our Ending the Epidemic community forums going forward into the future. And we will continue to work with our focus groups and stakeholders to continue to get information from our key stakeholders and have their input going forward with our project. My information is on the first slide, and you can contact me if you have any questions. So that's what we have going on.
Thank you so much, Shel. Next, we have Cynthia Turk, who is a health education specialist too with the HIV prevention program in San Bernardino County.
Hi, good morning. Thank you, Elena. So for San Bernardino County, the program coordinator is Heather Cockrell, so you have her information there, but I'm the lead for the HIV prevention team, health educator here with the program. Next slide. So here in San Bernardino County, from 2016 to 2018, we had a 21% increase in newly diagnosed HIV cases. We are a big county. San Bernardino County is a huge county with 2.1 million residents. So the Department of Public Health does have services, HIV services that, cover the 4 pillars. We have HIV prevention. We have a prevention program, which includes the testing, rapid testing, linkage to care services, linkage to PrEP, condom distribution program for venues. And then more currently, we are working on supporting local syringe service programs in the area. So the other thing we have is the care. We have 3 federally qualified health centers that provide specialty care, HIV care, 3 of them throughout our county. They do routine HIV testing, or they should be starting that up if they haven't already. We have the ADEP enrollment sites at those 3 health centers. Our surveillance team consists of our communicable disease section, and they do the disease investigation services and partner services as well. And then of course we have our support services like Ryan White program for HIV clients. But despite that, the services, the robust services that we have here under public health, there are significant populations that are still being missed. So if you see on our little graph there, we have identified affected populations that haven't been reached effectively, and so and then from there we then assessed each of them to what extent have they been at the table for us. So in our priority populations, we do have 6 listed there for new voices that will be coming in or focusing for our the Ending the Epidemic grant. Next slide. So as I had mentioned, so our county is big. It's people who live, we have different regions, people who live in the high desert. We have regions, the west end, the central, the desert areas, and even in the mountains. People who live in what we could call the high desert, if they needed services that they could only get down in the central area, it is about an hour drive for them. So because of that barrier, transportation barrier, and how the lacking of care sites in our desert areas, our proposed plans activities were to have a rapid response team, which would include a mobile clinic. So that clinic would include services such as testing, HIV care on the spot, PrEP services, and of course it would be focused on the underserved areas that have the transportation barriers. On top of when I say testing, I mean the HIV rapid, along with HCV, along with any STD testing. As Kevin had mentioned earlier, we do want to bring that marriage back for STDs, HIV, and Hep C. Another service would be the Rapid Start Initiative. So if we were to identify somebody who newly diagnosed as positive, we do want them to start the medications and treatment immediately. As studies have shown that they tend to adhere better if they start it right away. So with that, we would include health educators, we would include providers who are authorized to prescribe the Rapid Start, the PrEP, any of that. We would want to include peer educators. So as we all know, to incorporate and to practice cultural humility within our programs, we believe that including the peer educators can help build that. It can help build that trust. The peer educators will come from a background of shared experiences of the priority population that we want to, that we're trying to target. We will expand on the HIV prevention services for people who inject drugs, which is included, if you want, next slide. These are our activities for our community engagement. And so, as you can see, we've completed caucus meetings, community forums, substance use provider and client key informant interviews will be taking place in the near future because, again, as you saw on the last slide, we want to incorporate services for people who inject drugs. So key informant interviews will be conducted in the future for that. Collaboration with neighbor counties because of the migration patterns that we have seen between the counties and San Bernardino County, the neighboring counties in San Bernardino County. We do want to have a very effective collaboration between them. And then, of course, our planning council, our Inland Empire Planning Council, will be engaged in these activities and meetings as well. And that's it for San Bernardino.
Thank you so much, Cynthia.
You're welcome.
Next, we have Lauren Brookshire, who's the Assistant Medical Services Administrator for the HIV, STD, and Hepatitis branch in San Diego County. Welcome, Lauren.
Thank you, and good morning from San Diego. Thank you for providing me this opportunity, and today I'm going to provide you with a high-level overview of our Ending the HIV Epidemic work. Next slide, please. Starting with our priority populations. While you'll see in the blue box, we have several populations who have critical voices and a critical focus. We are focusing heavily on 3 populations. And these are Black, African American, men who have sex with men, people who inject drugs, and people 20 to 39 years of age. And these populations were selected based on our local HIV care continuum. Each of these groups have statistically significant lower rates of receipt of care and or retention in care and viral suppression when looking at both our cumulative data and also a recent subset of data for 2013 to 2017. And so ultimately we want to improve the health outcomes for all of these groups. Next slide, please. And now I'll review our proposed End the Epidemic activities. These activities were selected on where there were gaps in our current system. So you'll see several activities here. We plan to do routine HIV testing implementation grants. So in San Diego, we have a prolific system of routine testing in our federally qualified health centers. We want to expand this to our major healthcare systems, emergency departments, and community clinics. The idea behind this is to provide startup funding to establish routine testing and linkage systems where they don't already exist. And so we plan to conduct 1 to 2 startup programs for each year of this funding. The next area is benefits navigation. This is status neutral services for persons living with HIV who need ART and also persons vulnerable to HIV in need of PrEP. And I know there's been a lot of discussion this morning so far about various benefit linkages. The next item supports an advisory committee for ending the epidemic, which may become an arm of our current HIV planning group. We'll see how that rolls out. Next, we're looking at wraparound services for people who inject drugs. This includes HIV, HCV, and STD testing, linkage to PrEP or ART, and linkage to substance use disorder treatment services. We're also looking at peer-based mobile PrEP. We want to take PrEP on the road using a peer-based model in conjunction with medical services and medical providers. And we want to create a Getting to Zero application and resource guide. This is something that has been requested for some time by members of our HIV planning group. way back before smartphones and everything. We had a paper resource guide, and some people still have sort of some tattered copies of that and have asked for us to update it and make it both electronic and paper versions available. And lastly, we're looking at surveillance program improvements, largely in part to bring our surveillance data into more of a real-time realm. Next slide, please. So what have been some of our activities so far? In 2019, we had a kickoff presentation with our HIV planning group to introduce the Ending the HIV Epidemic initiative. In February 2020 of this year, right before COVID hit, we collaborated with the San Diego CFAR to host a community summit. We had a great turnout with approximately 100 participants. We limited provider participation so that it mostly consisted of persons either living with HIV or vulnerable to HIV. And later that day, we held a PrEP listening session, which was an opportunity for people to talk about their experiences related to PrEP. And then this spring, we've also had a series of virtual key informant interviews and priority groups to further assess the needs and ideas for community engagement with the critical voices we identified earlier. And so as with everybody else, because of COVID, we've had to make some shifts in terms of what we've done this spring and what we're planning for the future. That concludes my presentation for today. Thank you.
Thank you so much, Lauren. Next, we have Hannah Huard, who's the HIV/HCV/STI Behavioral Health Coordinator in San Francisco, and Bill Blum, who's the Director of Programs and the Primary Care Director for HIV Health Services in San Francisco. Welcome, Hannah and Bill.
Hi, thank you. This is Bill. It's a real honor to be here, and I will be kicking off the presentation, and then Hannah will step in at a few slides in. I was just reflecting just at our last CHIPS presentation that we gave was in January in San Diego, and just how much has changed since then at a national level, but also kind of the amazing work that our colleagues in other jurisdictions are doing. It's great to see. If you'll notice on our opening slide there, you'll see a lot of logos at different groups and organizations and sections and branches within San Francisco DPH, which I think is meant to share with you. It's a lot of people coming together, and this is kind of building on a number of plans and groups to get where we are today, and to our current iteration for our ETE plan. Also want to draw your attention to our title. We actually did submit to the feds that we did want to see it as a syndemic and looking at HIV, HCV, and STIs. Great to see how many other people have kind of come to a similar place with that. Also want to give a shout out to Vicente Consultants, who's helping us put this all together. Also to acknowledge the work we have in ETE steering committee. So in part what Hannah and I are presenting is the work that a large number of people have done. And finally, I want to give a shout out to Hannah, who not only is doing this, but is still activated in our COVID response. Next slide, please. So we wanted to start by kind of sharing kind of our overall guiding principles. The first one to draw your attention to is the health equity and racial justice. And this actually, we have seen our ETE work kind of embedded in a larger project, which San Francisco County has taken on to really look at health equities with the specific focus on Black and African Americans. I've already addressed the issue of the integration. We also have historically really tried to have a focus on looking at stigma and how to reduce and eliminate it. Low barrier services is our fourth. And then really working hard to have people who have lived experience and also to fund peer delivered services. Next slide, please. So in terms of our current planning for PS 1906, you can see some of the people whose logos appeared in the front. Really, we're kind of pleased at our work and that we've been able to get so many people together. And I think Hannah and I presenting together is part of what we try and do also to message the community that we're working together. As I mentioned before, we really have a strong focus on equity work, and that's a lens through which we've identified community partners. You can see the list of those folks there, and they match kind of the groups with less good health outcomes and wanted to involve them in all phases of both the planning and implementation. To this point, our community partners have given kind of 2 rounds of feedback as part of the plan development, and we'll be continuing to work with them as we go forward. And now I'd like to turn over the presentation to Hannah.
Thank you, Bill, and good morning, everybody. So in addition to the HRSA EHE funding, we are also being funded for Component A and Component C of the CDC funding. So next slide, please. And Component C will be implemented at the San Francisco City Clinic, which is our municipal STD clinic. Overall, our plan activities will complement our core activities and will be focused on communities with the highest disparities. There will be an increased focus on self-testing and telehealth services due to the COVID-19 pandemic. And the MHAPs are mobile services that go to communities, including street encampments, and will offer HIV, HCV, and STI testing, PrEP, contingency management for substance use, harm reduction services and supplies, and other referrals. And we're also exploring blended funding streams so that we can expand status neutral services for people experiencing homelessness, linkage navigation for people exiting the criminal justice system, and also for people who are seeking gender affirming surgery. Next slide, please. Prevention activities will be focused on mobile sites, also housing sites, and expanding PrEP, harm reduction services, and services for youth. And in addition to the required activities, one focus of the Respond pillar will be working with CBOs and community members to develop messaging and educational materials related to cluster detection and surveillance in general. Next slide, please. So there are various ways for community to be involved, both through our existing planning groups and initiatives and the ETHE steering committee. And then as Bill said, we're going to continue to fund our community partners. And we also heard through the community engagement that community members really want to be asked, they want more than just being asked questions, and they want to be involved on a deeper level in planning and get further education, and also have this be a pipeline to careers. And so in response to that, and with Vicente Consulting, we're going to develop a community health leadership institute. And that's it for me. Thank you so much.
Thank you so much, Hannah and Bill. And now we have Julie Tolentino, who is the Ending the HIV Epidemic Program Manager for the Division of HIV and STD Programs in Los Angeles County. Welcome, Julie.
Hi, good morning, everyone. First, I'd like to thank Elena and the rest of the CHIPS team for coordinating this event and inviting all of us to share our EHE efforts. Similar to the other jurisdictions, and especially after the regional meeting in January, LA County was energized and excited at the announcement of EHE and had grand plans for implementation. However, we've taken the past few months or so to reassess and shift our EHE plan, given the deployment of our public health workforce, the capacity of service providers and consumers to begin to implement EHE, given COVID-19, the recent fires, and the ongoing political unrest in our communities and nation. We conducted needs assessments with providers, and in partnership with the Commission on HIV, a broader community assessment to not only assist our COVID-19 response, but to better plan for the future. Next slide, please. As far as our current EHE activities, many of you are aware that we recently held an EHE virtual town hall to spread awareness of the initiative, provided a broad overview of our EHE plan, and launched our 30-day public comment period for the proposed plan. With regard to home testing, we partnered with Take Me Home, a collaboration between Building Healthy Online Communities and NASTAD to provide free home test kits through a dating app. For the first phase, we focused on young MSM of color in high prevalence areas, and for the second phase, have opened it up to all MSM countywide. We began those discussions in March, and we were able to launch in August. We're also in the process of acquiring additional home test kits to distribute to providers and utilize with our own in-house programs. We are currently developing an emergency financial assistance program for people living with HIV, exploring partnerships to address gaps in mental health services, refining protocols for the facilitation of rapid ART and linkage to care, and developed a community mobilization program that will focus on community-led EHE projects, which we hope to launch in early 2021. For the prevent pillar, we are identifying ways to support teleprep and exploring potential partnerships to ensure all 6 county syringe service programs are conducting HIV testing, as well as linking clients to HIV prevention or care. Similar to other jurisdictions for the respond pillar, we are discussing next steps in building the surveillance structure at the Department of Public Health to better respond and monitor HIV clusters, as well as expand our partner services program. The last item I'll mention for our current efforts that we're very excited about is the creation of an EHE steering committee with members who not only represent a range of perspectives, but will leverage their extensive networks to help implement EHE. Next slide, please. Our planned EHE activities can be found in our EHE plan, but I'll quickly mention a few. We hope to implement routine opt-out testing in multiple settings, such as federally qualified health centers, community health clinics, emergency room departments, jails. We hope to increase yearly rescreening of clients with elevated HIV risk through the utilization of patient-provider communication tools. We hope to build a robust network of providers that will accept referrals for same-day rapid linkage to care. And we also hope to train healthcare providers during their medical training programs to support HIV prevention and testing practices throughout the rest of their career. Overall, we hope to develop or expand client-centered programming under EHE that will address health inequities and improve the lives of people living with or affected by HIV, especially in our priority populations and those that are experiencing financial hardship, homelessness, untreated mental illness, and substance use disorder. Next slide, please. So we encourage everyone to get involved. We want to hear from you and hope you'll review our EHE plan at our lacounty.hiv website, which will be the hub for all of our EHE activities and items. It's still in development, but our plan is definitely uploaded there. We hope that you will submit comments via our online system. I know everyone is jumping at the chance to read our 24-page plan, but if you would like the Cliff Notes version, you can start at page 14. Where the strategies and activities are listed in bullet form. And if there is anything missing, please let us know and submit it via the online form. We also encourage you to attend a Commission on HIV meeting or apply to be a commissioner for our local planning council. Visit getprotectedla.com for sexual health resources and HIV information. And lastly, please email our EHE initiative inbox if you or your organization, your clinic, your community, if you have ideas to partner and or are willing to implement EHE activities. We are all ears and looking to partner with anyone and everyone. I'll stop there.
Great, thank you so much, Julie, and thank you to all of our panelists for your great presentations today. So now we'll move into the live Q&A. We have already gotten a lot of great questions, many of which our presenters have been responding to throughout the session, but we'll have a little bit of live discussion here as well. So if all the presenters can join and turn your cameras back on, that would be great. Our first question here is for Commander Sandoval Rosario and Kevin Sitter. With PrEP app, Medi-Cal, and other insurance coverage, who does Ready Set PrEP benefit? Should this be promoted to undocumented immigrants more specifically? So that question again is for Commander Sandoval Rosario and Kevin Sitter.
Great. So I'll jump in, and I know my colleague Kevin can add. So the Ready Set Prep, as I mentioned, is open to anyone that does not have any type of healthcare coverage. And when we think about those communities, we know that those without citizenship status would be ideally. I also want to mention, and I'll pass it over to my colleague, that we, the PACE program, OASH is working closely with the Office of AIDS here in California to see how do we integrate it. The Ready Set Prep here in California, which California is unique because we have the assistant program, is really to help the person get started on PrEP. Because a nice thing about the Ready Set Prep is that it's very easy. There isn't a lot of paperwork, and you can get someone on PrEP immediately. And then think about how do you enroll them in the assistant PrEP program, because as Kevin mentioned, it covers all of those other areas such as medical appointments and testing that are beneficial. So Kevin, I want to see if you have anything else to add to what I shared.
Sure. We do acknowledge there's a redundancy in part because of the PrEP assistance program. However, the Ready Set Prep option is going to be utilized by people who go to one of those many pharmacists throughout the state of California saying, I hear about PrEP and I don't have any insurance. Hey, we've got Ready Set Prep. And then once they're on the Ready Set Prep, we will be informed and be able to help them transition into the AIDS assistance program, PrEP assistance program. And so I believe that it's a great jumping point, and I believe that there'll be many pharmacists throughout the state that are aware of Ready Set Prep, and that'll be the gateway for individuals to get into the program.
Yeah, and Kevin, the last thing I want to mention is that you don't have to be a PrEP provider to enroll someone into Ready Set Prep. So that is one of the key advantage. And then once the individual is enrolled, you can transition them to the assistant PrEP program.
And the PrEP assistance program is not part of the public charge at this time. We always want people to stay in touch with legal support when they are not documented. However, we want you to know that at this time, the use of PrEP AP is not going to be a vulnerability to public charge. And again, at this time, we all need to watch federal administration to see what happens next. But currently, it's okay.
Okay, thank you so much. I know we just have a couple minutes left. If you have more questions, feel free to continue submitting them, and we'll be sure to follow up with you. In my follow-up email, I'll include responses to any additional questions. But let's just cover one more here with our group discussion. So for the counties that are proposing to do home test kit delivery programs, how are you going to get the test results for those individuals to follow up and to ensure rapid linkage to care? So I know a few different counties are doing that. I think, Steve, you actually responded in a comment a little bit about Alameda County's plans, but Matilda, how about in Orange County? So how are you going to get the test results for these individuals to follow up and ensure rapid linkage to care?
Well, that's a good question. And so this is a planned activity, so we haven't necessarily implemented just yet. So we're working on developing those protocols. Something that I can mention in terms of something we're giving thought to as we go into this this project is we are actually currently, it's a pilot, but not necessarily that we're funding directly with EHE funds. But Orange County is partnering with Building Healthy Communities Online and NASDAQ, and I believe it was our colleagues from LA that are doing a similar activity. So we're working with that organization to provide the at-home test kits, and through this program, results are delivered through an online portal. So we may do something similar. Again, it's sort of a mini pilot outside of the EHE activities we discussed today. But again, we're going to take those best practices and lessons learned and apply them as we expand the program.
If I
Great.
can add.
Sure, Cynthia, go ahead.
So same as Matilda, we have we're gonna start doing the in-home testing too because of the whole COVID. And so our plan for that is to because we'll be the ones handling the kit and mailing them out. We will be ensuring that the mailed out kit is either tracked or certified so that we know that it was delivered. So it'll confirm receipt of delivery. Once we know that, of course, clients, if they call in asking for that in-home kit, we will be assessing them over the phone. And through that assessment, we'll already have contact information. And then during that assessment, we will also request them to call us once they have the results, once they've completed the test and they have those results. So it'll be more of a self-reported result. And so that's how we will, and if we don't hear from them, the plan is that if we don't hear from them within the week of delivery, of the kit delivery, we'll initiate the phone call or a text to follow up, say, hey, did you complete your test? And then go from there. Any further resources for PrEP or further testing for confirmatory testing or treatment, we'll determine after we get in contact to get that self-reported result.
Great, thank you so much. So I know that we are at our time today. So I just wanted to take a moment to really thank all of our presenters again for the wonderful discussion during today's session, and also my colleagues Dami and Nick for providing behind the scenes support. And most importantly, I want to thank all of you here on the line with us so much for participating in today's Learning Collaborative kickoff session. Please do look out for an email from me, should be by the end of this week, with links to the session evaluation form and also our new webpage, which will have information about upcoming EHE regional response events, and will also hold the recording from this session. So thank you again, everyone, and enjoy the rest of your day.